session, we've sort of turned into not just an unknown session. I kind of go over slides. If anybody wants to describe these, say, hey, don't leave us out. I'm happy to let you describe it, but it's sort of in contrast to some of the other sessions where we call on you from and expect you to go through everything. So I'm happy just to kind of go through these and tell you what I do when I look at these. And so here we've got a punch biopsy. Not the world's best punch. It didn't get all the way down to the lower reticular dermis. So, when you do a punch biopsy, it's better just to go ahead and, punch all the way down to the barrel of the punch where you're into the subcutaneous fat. So when you pull it out, the specimen can come out of there easily. This one looks like they kind of went into the reticular dermis here and didn't really get all the way deep that they should, but that's okay. At least we can look at it. It's not crushed or anything like that. And you can see low power. It's got a mostly perivascular infiltrate of these dark cells, so they're mostly going to be lymphocytes here. I mean, we may, as we go to higher magnification, we're going to look to see if there are any eosinophils mixed in there. We look to see if there may be any neutrophils, anything like that. But certainly at low power, it looks like mostly lymphocytes. And the other thing that should strike your eye is that you've got this massive pallor of the papillary dermis right beneath the epidermis here. This is massive papillodermal edema. There's not a ton of diseases that give that. So whenever I see that, it instantly kind of narrows my differential down into literally just a few things. I start thinking about maybe the most common probably be a bullous insect bite reaction. There we'd expect to have some EOs down here, especially, somebody that may be immunocompromised. It's kind of a relatively new described entity. It's been around for a long time, but it's hit the literature. Warren Heyman described, he had a nice article about this in his little editorial that he does in JAD about a year ago. And it's basically some people that have mild immunocompromised, maybe an underlying lymphoma or something like that, CLL, they get bitten by an insect and they get a massive response. We used to see this back in the old days with patients with HIV infection and low CD4 counts. They would get an insect bite and then they would get massive response to it. And they would also get recall of insect bite reactions they have in other locations. And we've seen that with this sort of hyperimmune response to arthropod assaults and other insults in patients with generally relatively mild immunocompromise. It's not like patients that have no neutrophils, like a patient that's undergoing chemotherapy or somebody that's on a biologic. It's usually something like a low-grade lymphoma. So that's probably the first thing I would think about at low power. The one thing against that, if there's really no epidermal change, you sort of expect to see maybe a little crusting when the insect bite happened, unless you're off to the side of it. Another thing that can give you this type of massive papillodermal edema, sweets. There you're going to see a dense infiltrate of neutrophils in the dermis. We don't really see that pattern so much here. That would be kind of diffuse. Everything would be inflamed here, and we have areas it's mostly perivascular. So that would be a little bit against it. Sometimes you see this with things like Bullous tinea infection, interestingly enough, can give you marked papillodermal edema. We rarely see it in things like dermatomyositis and lupus. And then probably another fairly common setting is in polymorphous light eruption. So if we see a lymphocytic infiltrate with this pattern, and generally not a lot of epidermal change, interestingly enough, in PMLE, that's the most likely diagnosis. And as we go to higher magnification here, there are not any eosinophils here. So it is mostly just lymphocytes. And with this marked papillodermal edema, and notice there's really no mucin here. This is all solar elastosis. Probably the best diagnosis in this case would be polymorphous light eruption. And so that's what we thought it was. It seemed to fit best with the clinical. So that's, a relatively short list of things that can give you this marked papillodermal edema. Sometimes severe stasis change can do it also. But the good news is there's certain things when you see it histologically, there's not that many things that cause it. And then you look at these secondary factors, looking for the presence of the diffuse neutrophils, for eosinophils, for mostly lymphocytic infiltrate around here. And then you'd maybe look at the cornified layer, make sure there's no crusting or things that could tip you off to maybe it's a fungal infection. There's no marked stasis change here, so it's probably not just edema from massive lymphedema, that sort of thing. So anyway, that's a nice example of what you would expect to see in PMLE. And PMLE is one of the 5 to 8 L's that can give you lymphocytic infiltrate. So there is a form of PMLE where you do not get the papillodermal edema. It just gives you a straight lymphocytic infiltrate. But if you do see lymphocytic infiltrate with the papillodermal edema, that's really should be number one thing that you really should think about. Okay, take a look at this one. So now we have a punch biopsy once again. See a little bit of inflammation, but we really don't see a lot. So if it's going to be an inflammatory process, it's probably going to be, something like a sparse perivascular dermatitis, maybe a drug eruption, maybe atopic dermatitis, maybe a subtle, contact dermatitis or atopic, something like that. But you can see even at low power, the epidermis is not normal. It's markedly thickened and acanthotic, and it's not regular acanthosis. So it's not like what we would see with psoriasis, for example. So when you get irregular acanthosis, you start thinking about other things, maybe like atopic, lichen simplex chronicus, long-standing chronic allergic contact dermatitis, those sort of things. And then you start asking yourself what part of the body we're on. There's not many hairs here, but there are a lot of smooth muscle bundles here. There's a lot of them. So we're in an area that might be an erectile tissue. Whenever you see this many smooth muscle bundles, start thinking of things like the scrotal skin, the areola, things of that nature where there's erectile tissue. That's not your normal number of hair follicles that you just see on glabrous skin where there's a few hair follicles. So clearly that's either a neoplasm of smooth muscle or it's one of those things. Well, let's look at the epidermis and see why it's so acanthotic. So again, if this were the breast or the scrotum, again, the differential diagnosis is relatively limited when you're biopsying those areas. So you start thinking about, well, why do dermatologists biopsy those areas? Maybe they're looking for something like, again, allergic contact dermatitis, some inflammatory process, something like that. If you're taking a punch biopsy. And then one thing that we always teach you guys and others is if you see a long-standing erythematous inflammatory eruption in those locations and it doesn't respond to therapy, then you want to always consider the possibility of extramammary Paget's disease or Bowen's disease or Langerhans histocytosis or in neoplasms that can affect those areas. So don't give it too long when you're looking at kind of a red, inflamed, eroded area in those locations. If it doesn't respond fairly quickly, your probably initial diagnosis is going to be something like maybe a fungal infection or an inflammatory process. And if it doesn't respond within the first, few weeks of therapy, you need to then say, well, let's just take a biopsy to make sure that it's not one of these other more dangerous diseases. And the vast majority of the time we get biopsies, and it's not more dangerous, it's just maybe a refractory contact dermatitis. Maybe they're still using something that's causing the allergy. But in some cases, it is that. So if you look here, with a higher magnification, we do see some abnormalities here. And you can see within the epidermis are these cells here. They're arranged throughout the epithelium at all layers of the epidermis are involved, except perhaps the very, very lowest part of the basal cell layer. Some people refer to that as an eyeliner sign, sort of residual normal keratinocytes, and then the neoplastic cells are present just above that. Not like in, Bowen's disease or melanoma in situ, where that's usually involved. In this condition, which happens to be a mammary Paget's disease this time, you get the basal cell layer is spared a little bit. So that's actually relatively common. So that it's not a pathognomonic finding, but it's more commonly seen than when you're dealing with the other intraepidermal pagetoid neoplasms. Now, there's a differential diagnosis when you see this pattern. If you're on the breast and you see it, you're probably and you see this where you're not getting full thickness atypicality, you got these cells sprinkled throughout the epithelium. You probably don't really even need to progress down the differential diagnostic pathway of melanoma in situ and some of the other things that can cause this pattern. Here it's basically mammary Paget's disease, and I'm not even sure in this case we even did any special stains on it. But if you were concerned, let's say that it did have features that really simulated, pagetoid squamous cell carcinoma in situ or melanoma or pagetoid reticulosis variant mycosis fungoides or Langerhans histocytosis or Merkel cell carcinoma, which can give you a pagetoid pattern, or sebaceous carcinoma, which can give you a pagetoid pattern. I think that's about all of them. You would stain this up and you would work it up to rule out some of those other entities. Obviously, for this lesion, the most commonly positive marker is cytokeratin 7, but CEA is positive, and if you do a mucicarmine stain, which stains epithelial mucin, as opposed to colloidal iron, which stains the connective tissue mucin, it would be positive. So this is mammary patch disease. Now, the other thing about this that you have to know is that basically every single time you see this, in fact, 100% of the time, basically, it's associated with a contiguous underlying intraductal carcinoma of the breast. So if you see this isn't like extramammary patch disease, where a fair percentage of those are not associated with an underlying cancer. This lesion almost always is, and so you're obligated to look for it. You need to do a mammogram. They're going to go do breast biopsies. They'll excise this, and then they're going to probably be doing a deeper excision too. So this thing, you don't want to just, this isn't like squamous cell carcinoma in situ. This is associated with the underlying breast cancer that the patient can die from. So it's actually, if anything, probably a lucky thing if it presents in the patient, because it's a cutaneous manifestation of an underlying cancer. The only other thing that we sometimes see occasionally is male mammary breast cancer. So that happens on occasion. Usually the little small residual vestigial ducts of the breast tissue that men have, they don't have the breast glands as a general rule, unless they have gynecomastia, but even then they're mostly just ductal hyperplasia. You can get mammary patch disease in a man, and you can also even get it in the accessory nipples in the milk line. So we've even seen mammary patches disease develop in that location too. So anyway, that's important. You need to make sure you know the differential diagnosis of the pagetoid neoplasms and the stains that go along with each one of them, because that will almost certainly be something that you'll face on the board examination. Okay, this next case, and another punch biopsy taken, it's like cut in half here, so like probably maybe a 5 or 6 millimeter punch. It's a large lesion, and you can see it low magnification. Looks like an inflammatory process. And you remember the 9 patterns of inflammatory skin disease. It looks at low power like there's something going on in the follicles. So folliculitis and perifolliculitis is one of the patterns. And so it means that there's inflammation in the follicle. Folliculitis doesn't mean suppurative folliculitis. You can get eosinophilic folliculitis, spongiotic folliculitis, herpetic folliculitis. So it just means inflammation of the follicle. We tend to sort of make it synonymous with bacterial folliculitis, that sort of thing, but it's just a pattern. And clinically, you can see inflamed hair follicles. Histologically, we see inflamed hair follicles. So just notice that every one of these follicles has got some inflammation targeting it. Now, where is the inflammation? You can either have it in the follicle itself, or you can have it around the follicle. That's what we call perifolliculitis, or it can kind of be both. It can involve areas around the follicle and in the follicle. And if you look here, low power, it looks like there's a lot of inflammation that's actually targeting the follicle itself. And there's some, maybe a little bit of around the follicle, but this is mostly folliculitis here. There's one other thing that you can tell at low power is that there's some clear material that's in the follicle. And there's really only 2 things primarily that can do that. One is spongiosis in the follicle, and it can be so marked as to give you little spongiotic microvesicles in the follicle. And the other is mucin in the follicle. And in this case, it happens to be mucin. And as you go to higher magnification, you can see it's kind of got this grayish blue color, just kind of like the same mucin we see in the dermis in patients with GA and lupus and dermal, myxomas, things of that nature. So it's mucin, it's not spongiosis. Some of this may be some spongiosis over here, but there's definitely mucin in this follicle. And just like the mucin that you see in the epithelium of extramammary Paget disease or patch disease that we just saw a second ago, This is epithelial mucin. It's not produced by fibroblast and histiocytes like the mucin out here. This is mucin that's actually produced by the keratinocytes themselves. And it's kind of curious that the hair follicles develop the ability to produce mucin. It's probably, I don't know what the pathophysiology of that is, but basically something is going on here and causing these cells to produce this mucin that's within the follicles. It's kind of an interesting phenomenon. Now we see that it's really seen in only 3 settings. The most serious setting you need to be concerned about is mycosis fungoides, because it can cause follicular mucinosis, present like with little follicular spines. They usually have evidence of patch or plaque disease elsewhere. They don't always have to have it. So that's the most serious disease you need to be concerned about when you see that. The second is alopecia mucinosa, which is often seen in young individuals, children in some cases, and they get just a solitary plaque, usually on the head and neck area. It's boggy. It kind of clinically looks like maybe some type of contact or irritant dermatitis. You biopsy it and it shows this. And then the last case is where it's just kind of a reaction pattern. We see patients sometimes that have rosacea and they can get follicular mucinosis. Sometimes it's just seen kind of coincidentally. You biopsy it, maybe they've got, maybe atopic dermatitis, and lo and behold, they got some focal follicular mucinosis. So it can sometimes just be a coincidental finding. So not every case that has it has MF. But that's the most important one you need to concern yourself with. The way to tell that apart is you look for the atypical lymphocytes. You look for areas where there's mycosis fungoides in the overlying epidermis or in other locations. So those are kind of the things that you do. If you're not sure, you can order T-cell gene rearrangements. Alopecia mucinosa usually is associated with a fair number of eosinophils in addition to the lymphocytes here. So it can be difficult to tell, and you need clinical correlation, and sometimes you end up having to do additional studies to rule it out. So if somebody just sends this in as rash unspecified, that's really not enough information. You really need to make sure that they don't have other stigmata of MF, or that it's not just a solitary plaque in a kid. You wouldn't want to overcall that, but you certainly wouldn't want to undercall if somebody actually had MF. So a case like this, I'm not sure in this case which one it is. I think this was just alopecia mucinosa in this case. But the most important thing is just recognizing the pattern here and understanding the differential diagnosis when you get follicular mucinosis like this. Okay. And the next one is kind of one of these sort of interesting sort of gee whiz type of cases. And it's basically looks like an enucleation type of biopsy. And I can tell you this presented as a kind of what they thought was a subcutaneous nodule. A lot of times things are thought to be subcutaneous and they're really in the dermis. So, you feel a patient come in and say, well, this looks like a subcutaneous nodule and it's a cyst. Well, most of those cysts are not in the fat. They're usually sitting in the reticular dermis. They feel like they're beneath the skin, but they're actually in the dermis. So they're not truly subcutaneous. And this is the same thing. This thing is sitting here in the dermis, but it probably felt like a dermal nodule. And they thought it was a subcutaneous lesion. This also came from the area around the umbilicus. Okay. So they were most likely concerned about, Sister Mary Joseph's nodule, which is, I think they even had a question about that on our board examination a number of years ago. And that is basically a metastatic gastrointestinal or sometimes GU tumor that presents in the umbilicus area as a nodular lesion. And actually, Sister Mary Joseph was a scrub nurse at the Mayo Clinic many, many years ago, and she was in the operating room with those surgeons there, and she noticed that it seemed like that every time they saw a patient that had one of those nodules in that location, they always died, and they always had underlying carcinoma, and so they named it after her. So again, if you see a nodule in the umbilicus area, that's the most important thing that you want to rule out. In this case, this was a lesion that was painful, and it had been painful in a cyclical fashion. And this was from a woman. And you can see it's got this kind of curious material here that almost looks like a cyst. And you start looking at high magnification, it's got these little tiny, look like little I don't know, little tiny leaves of grass, blades of grass blowing in the wind, I guess is a way to kind of describe it. Those are little cilia that are on the surface of these cells here. So this is a ciliated epithelium here, and it's got a single layer of cells, a little slightly elongated and mostly cuboidal. So that doesn't look like it comes from normal skin. This is not apocrine differentiation. This is ciliated epithelium. And then you look at this material in the center, it's got this somewhat myxoid stroma. It's got these round cells in here. It's got all these erythrocytes in it. And basically what this is ectopic endometrium. And this is cutaneous endometriosis. And here's the scar that you can see here. And so this can be seen in a lot of different settings. Probably the most common setting is someone that's had a C-section previously. And then this, it's thought that what happens is that there's traumatically implanted endometrium that gets into the scar tissue where the surgery was performed. And then it, forms a little nodular aggregation like this. And then it actually is hormonally sensitive, just like the regular endometrium is in the uterus, and it undergoes the same cyclical phenomenon that goes on with menstrual cycles. So it's painful, and it gets painful around the same time of the menses. So that's a clue to the diagnosis. It usually kind of presents as a skin color to brownish black nodule. It sometimes gets submitted as rule-out malignant melanoma because it's got a dark color because of the hemorrhage that's in it. It's not that the epithelium is pigmented, but it's just that it has the hemorrhage in it. I don't think they'll show you this on the board examination, but it's just an interesting phenomenon that you may encounter clinically in your practice. So it's not anything to worry about. It's not cancerous. It's not, I'm sure there are probably case reports of these becoming malignant, like you can get endometrial carcinoma, but that's super rare. And it's usually just one of these sort of interesting findings. And thank goodness it's nothing serious when you tell the patient it's not metastatic carcinoma. Okay, here's another nice example, and this is one that very well could be on your board examination. If you look at low magnification, you've got this normal appearing piece of skin here, and then you got something beneath it. And so probably what they did, this once again probably felt like a subcutaneous nodule here, and it's really maybe in the dermis itself. What they may have done is taken a punch and taken the top part of it off, and then basically enucleated the rest of it out of here. Okay, and whenever we think of an enucleation procedure and something really does sort of shell out, that is a histologic sign of benignity. Just like when you see someone with a pilar or tricholuminal cyst, and you go in and make a little incision on top of it, and it pops out like a little marble. Well, those are almost always benign. The same thing is true here. When you get this kind of procedure done on this lesion, it's not a cyst, but it's almost always benign. So it's a neoplasm, benign neoplasm, and always we ask ourselves first, is it benign or malignant? Okay, we think it's benign. Is it epithelial or non-epithelial? And so when you look at low magnification, I don't really see anything that looks like an epithelium. So let's look at the epithelium up here that's kind of in contrast. Does it look like the stratified squamous epithelium in the epidermis? Well, no, it certainly doesn't look like that. Does it look like a hair follicle? No, it doesn't look like any of the parts of the follicle. It doesn't look like a sebaceous gland. It certainly doesn't look like an eccrine or an apocrine gland. So it's non-epithelial. And when we think of non-epithelial lesions, there's really three main ones that you need to know. There's others if you want to go into dermatopathology and you want to get into, some bizarre things that Jared Gardner talks about, soft tissue neoplasms. But the three main ones that you need to know are muscle, fibrohistiocytic, and neural. Those are the three main non-epithelial sort of spindle cell-like lesions that you really need to know about. And so the way to tell those from one another is you start looking at the nuclei of the cells. You see, is there, how much cytoplasm is there? This one's got a lot of pink cytoplasm here. Muscle lesions generally have kind of these blunt, cigar-shaped nuclei. They're not really lazy-esque, like they're swimming in the pond like a fish, like we see as neural nuclei, and they don't have a mucinous stroma like we see with fibromucinous stroma like we see with neural lesions, no mast cells, anything like that. And they don't look like little zigzag, clones, like they're forming these sharp angulated aggregations, or they're stellate in shape and size and structure like we see with fibrohistiocytic differentiation. So this would be most likely muscle differentiation here. And so if it's a benign neoplasm with muscle differentiation, we know the diagnosis is a leiomyoma. So that's, we're 90% of the way there just based on that. Well, there are two leiomyomas that you need to know about. One is an angioleiomyoma, which means that the lesion arose from, or it's differentiating toward the large muscular wall of the larger blood vessel, like we see here. So here's the vessel that's sitting in the middle of it. So this is an angioleiomyoma, and those lesions look like little round nodular lesions like this. They look like little marbles in the skin. So at low magnification, and if it's muscle, you would instantly say this is an angioleiomyoma. And then we get a piloleiomyoma, which are basically leiomyoma, which are, they almost look like that areola that we saw a minute ago, where you just get the smooth muscle bundles that are present diffusely in the dermis. And you can get leiomyomas of erectile tissue as well. So some people break out pilar leiomyomas into the scrotal or areolar leiomyomas, that sort of thing. That's sort of just, it's a little subtype, if you will, but that those are coming from smooth muscle bundles that are associated with hair follicles, at least in some areas. So they're subsets of pilar leiomyomas. So those are really the two. The only other thing you need to know about leiomyomas is that there are the malignant variants, and those are usually larger, they're asymmetrical, they have atypical cells, they have mitotic figures. There's a so-called atypical leiomyoma where they have some mitoses and some atypia. They're thought to be heading towards a fully developed malignant leiomyosarcoma, but we call them atypical if they're still relatively small. They just have some atypical cells in them, and they usually recommend removal of those, just so we don't want to leave them alone to kind of turn into something more aggressive. And then, of course, you have the fully developed aggressive leiomyosarcoma. Now, the one interesting thing about leiomyosarcomas in the skin is that even if they're malignant, they behave in a relatively indolent fashion, sort of closer to, and not even really as aggressive as DFSP. They hardly ever metastasize. So that's kind of the good news about it. But you don't want to just leave it there forever, because they can metastasize. And the last thing that you need to know about leiomyomas is they can occur in multiplicity in patients that have Reed syndrome. And again, that's sort of analogous to Muratori. They get underlying GI carcinoma. They're associated with microsatellite instability. So make sure you know that. They could easily show you an example of a pilar leiomyoma and then say what syndrome is associated with this, or what underlying cancer is associated with this. So just make sure you know that also. Okay, so pretty one. So we've got an excisional biopsy here. So once again, clinician probably said, boy, this looks like a tumor, it's some kind of neoplasm, a dermal-based process, and they might have had a prior biopsy. They might have just elected to excise this en bloc. They might have thought it was a cyst or something, and they were excising it. So many lesions. There's actually a nice article on the American Journal of Dermatopathology, I think just last month, where they talk about lesions thought to be cysts clinically that turn out not to be cysts histologically, and they list about 10 things or more that can do that. So we see a lot of lesions that come in as cysts. They turn out to be adnexal cancer, adnexal neoplasms that are benign, or even cancers. I've seen desmoplastic melanoma submitted as cysts. They're soft tissue neoplasms. So beware of things that are thought to be cysts clinically. But here we've got a neoplastic process, and it's obviously quite symmetrical. It's relatively small. You draw a line down the middle of it, and one side looks pretty much like the other side. Not poorly circumscribed. So it's got all the cardinal features of a benign process. And once again, step 2, is it going to be inflammatory, or is going to be epithelial or non-epithelial? And just like the last time, it doesn't look epithelial. It looks like something else is going on here. There's some pale areas in it. We don't see obvious epithelial differentiation here. So once again, we're going to ask ourselves, is it going to be one of those three types of differentiation? We go to higher magnification. And here, just like we had the follicular mucinosis a minute ago, we've got massive mucin in this lesion. Okay, so if it's one of our three non-epithelial lesions, do you get lots of mucin in a fibrohistiocytic lesion? Well, the answer is almost never. So that's no. Do you get it in smooth muscle lesion? Once again, no, not as a general rule. It'd be very, very uncommon to get a lot of mucin in that. But we do see mucin very commonly in the neural neoplasms. It's not uncommon at all to see quite a bit of mucin in a neurofibroma, in a schwannoma, so we see it. And in this lesion, which is a little different entity, but it's in the same family of those, this is a neurothekeoma. It's a nerve sheath myxoma, and it's myxoma. Mix is the stem. It's Latin word for Latin or Greek stem for mucin. So when you see a myxoma, you say, well, it's just got a lot of mucin in it. And then we look down here, and you can see it's got these nice little sort of nuclei. These are cut in cross section, but the ones that are longitudinal look like they are kind of lazily swimming through this sea of mucin here. So those are your cells of the neural lesion. Now, not every neural cell is spindle in shape. We know that nerves, they form ganglia. Schwann cells are not always spindles. Sometimes they can be somewhat epithelial. There's also sustentacular cells other than Schwann cells that are associated with nerve cells. So not every single neural neoplasm has got those nice little lazy S nuclei like we see over here. Sometimes they have some of these more epithelioid areas. And so we do see this in these neurothekiomas, and it's called neurothek because thek is the Greek word for nest. So it's basically a nested neural neoplasm in addition to the myxoid areas with the little classic sort of spindle cells. But here we also have an epithelioid component to it. So this is a relatively uncommon entity. There's also a version of this known as a cellular neurothekeoma, and those actually are not comprised of Schwann cells, and they don't stain positively with S100 protein. They stain with NKIC3, which is a different marker. And so it's not really a Schwannian cell. It's a different type of cell in that entity. This one probably does have some Schwann cells, but it's probably got some of the cellular areas as well. I'm not sure you'll encounter this on the board examination, but it's a nice example of just where we can come up with a differential diagnosis of neural pretty quickly based on the fact that it's non-epithelial. It's got a spindle cell component, and it's got a lot of mucin in it. Whenever you see mucin in abundance in any situation where it's in a neural neoplasm or something like that, you're going to see mast cells within it. So there's a mast cell right there. There's quite a few in here. If you ever biopsy a neurofibroma, you may notice that it tends to bleed a little bit more than, say, if you biopsy a melanocytic nevus, and that's because the mast cells also have heparin in their cytoplasm, and so that heparin tends to cause obviously the blood not to clot as well. So you might notice that the next time you biopsy a neurofibroma. Okay, this one is a nice example also. So I have a punch biopsy taken from, doesn't look like there's a lot of hair here, so it may be kind of close to volar skin. It may not actually be on volar skin itself, but it does have a markedly thickened cornified layer. And once again, this does not look like a neoplasm. It looks like an inflammatory process. And we see that it's got some little perivascular inflammation here, probably going to be mostly lymphocytes are really dark and black. And then we notice the shape of the biopsy, and it seems to be a square biopsy, okay? And also, if you notice at low magnification, the collagen does not look normal, even at low magnification. Maybe we can kind of go back to one of these others where we had some normal skin here, just to kind of show a contrast. Okay, so you look at this collagen here, and you can see that it's got spaces between the collagen bundles. It's got a hair follicle here. Notice how this isn't a square. It's almost kind of like it's a V shape because it's got nice elastic tissue in there. So if you take a punch biopsy and you pull it out, You'll notice how it's the epidermis is kind of, it's almost kind of forms almost like a little porte-cochere. It's got a little, it's sitting out a little further aside from the dermis like that. You'll see that grossly when you remove your punch biopsy. And that's because the dermis basically is elastic and it squeezes in on itself. And you don't need to take your forceps and help that along. But that actually happens when you just remove the skin normally. Well, we'll go back to this, our other biopsy here that we're looking at. And notice that that didn't happen here. Certainly not to the same degree. You know, it does look more like a box. And there's a little bit of that, but it's certainly not the same degree that the other one did. And there's no little spaces really between the collagen bundles like we saw before. So we refer to that as homogenization of the collagen bundles. And we see homogenization and a decrease in the number of fibroblasts. We refer to that as sclerosis, sclerotic collagen that we see. Now, some people talk about necrotic collagen. Collagen can't die because it's not a living structure. It's a fiber. So you can't have necrotic collagen because it never was alive. It's like you can't have necrotic keratin. You know, that's never been alive. So you don't talk about necrotic collagen. Talk about degenerated collagen. You can talk about, you know, degenerated keratin or keratin that gets digested by bacteria, you know, things like that. But you don't talk about necrotic collagen. That's why I don't like the term necrobiosis, which really refers to palisaded granulomatous dermatitis with some degenerated collagen in the center. I've just never liked that term. It's in the literature, but it sort of means death life, and it means really that you've got something that was living and then it's degenerating. But anyway, I don't like that because it's not really a precise term. It's really better talking about degenerated collagen, sclerotic collagen, that sort of thing. So that's one of the 9 patterns. Sclerosing and fibrosing dermatitis. So we put that in there because fibroblasts and histiocytes, they are also in the inflammatory disease categories. They're inflammatory cells. They're associated with inflammation. And so that's why it's in there. And I think it's good that it's in there. So this would be in the category of the sclerosing and fibrosing conditions. And as we go to higher magnification, and we see this kind of sclerosis, the number one thing that we think about is obviously morphea or scleroderma. And notice that there are some fibroblasts still, but there's very few. They're way decreased in number. And notice that these collagen bundles, they're homogenized. They're just little fractures between these, but this is not normal collagen. So this is abnormal. And one other thing that you'll notice in this inflammatory infiltrate here is that there are plasma cells and lymphocytes. So we always basically, in very high percentage of cases, you will see residual plasma cells in morphea and in scleroderma. And if we look down here, they're often seen at the edge of the fat that's being replaced. And one of the reasons there may not be any residual adnexal structures. And here's some erector pili muscles here. So that tells you there must have been a hair follicle at one point. It's all replaced by the collagen. So once it gets sclerotic, it starts just destroying everything in its wake. So any hair follicles get destroyed, you know, any residual sweat glands get destroyed and replaced by the sclerotic collagen. Fat gets replaced by the sclerotic collagen. And so it just turns into this big, thick sclerotic plaque. And it's often has sort of a pinkish lilac color when it's in an early inflammatory stage. In the later stage, it becomes more white or brown. And then when it becomes atrophic, it actually starts looking more like a gully. And it becomes brown, usually clinically. And there, you'll actually start seeing the sclerosis sort of turns into more of atrophy. And that's what we see with so-called atrophoderma piscini and perini. Early inflammatory morphea or scleroderma will give you an interstitial infiltrate. So this has still got some inflammation on this part of it right here. Hasn't gotten quite as sclerotic yet as the rest of the specimen. And so you kind of like to get it when it's in an early stage and it's inflammatory. And you'll actually often see eosinophils in early inflammatory morphea that could be interstitial. So we see that as well. Now, the other thing that you need to know is that this is also a reaction pattern that can be seen in a number of different conditions. So if we just see this, we can't say, the patient's got morphea. patient might have lung disease. They might have atherosclerosis. They may have classic CREST syndrome. They could have sclerodermoid graft versus host disease. They could have sclerodermoid porphyria cutanea. So they could have been exposed to toxic oil, or the people were taking melatonin years ago that was contaminated with things that cause sclerosis. So basically, it's a reaction pattern, and you have to have clinical correlation to make a final diagnosis. But they basically all look very similar to this. So this is a beautiful example of the sclerotic dermal reaction pattern that we see in Morphea. This was somebody that had Morphea this time. Okay, shave biopsy, a fairly large nodular kind of lesion. Ask ourselves whether it's an inflammatory neoplastic process. It looks like a large, well, just a nodular proliferation of some cells in here. They don't look spindle. They look sort of like they could possibly be inflammatory cells. So well, maybe it is a neoplasm, but it may be a neoplasm of inflammatory cells, like a lymphoma, for example, or maybe like a pseudolymphoma, something along those lines. So, leukemia. So you can get neoplasms, benign or malignant neoplasms, where the cells are not epithelial and they're not spindle, but they can be the inflammatory cell lineage, Langerhans cell histiocytosis. Those kind of lesions can all be associated with that sort of finding. So as we look at a low magnification, you can see that they're not all just dark and jet black. So if we thought this was a lymphoma, you'd expect everything to be jet black. So we can say, well, this could be a mixture of cells. There probably can be some lymphocytes in here, but there may be some other cells, and some of them are kind of pale. So there may be some histiocytes in here as well. So let's go down to higher magnification and see if we can see what kind of cells these are. And lo and behold, a lot of them are histiocytic, and they have multiple nuclei around them here. And they also have cytoplasm in some areas that's pale and somewhat foamy. And there's a whole lot of them. And we look in other areas, and some of them are more kind of spindle and probably more kind of like spindle histiocytes with probably some fibroblast here. There may be some, scattered lymphocytes in here that we talked about before, but there's not a predominance of lymphocytes. And so when we see a lesion that's got all these histiocytes and these large multinucleated cells with multiple nuclei around them, here's some hemosiderin in there, we start thinking of possibly a xanthogranuloma or xanthogranulomatous inflammation. Xantho means lipid, and granuloma means predominance of histiocytes. So this is xanthogranulomatous inflammation, and if it's a solitary lesion like this, it looks like a neoplasm, best diagnosis would be a xanthogranuloma. Now you can see xanthogranulomatous inflammation in a lot of other conditions than just a JXG or adult xanthogranuloma. You can see it in some of the non-X histiocytoses that you probably should bone up on. I'm not going to go through all of them in the talk today, but there's a whole list of the non-X histiocytoses. It's a relatively obscure topic, but it's something that the board might ask you a few questions about. I'm sure you'll study it when you go through your textbook chapters and things like that, but I would just recommend knowing about it. Some of them can be malignant, and some of them can be associated with underlying hyperlipidemia. So, I would recommend knowing that. Reticulohistiocytosis, multicyclic reticular histiocytosis associated with arthritis. That's in the non-X histiocytosis category. And then, of course, the Langerhans cell histiocytosis lesions too. So I would just know about those. But this is a nice example of a xanthogranuloma, and it's probably, I don't know if it's a kid or an adult that had it, but it's got these nice Teuton giant cells. You got these wreath of nuclei with this central amphiphilic cytoplasm, and then other areas where it's got the foamy cytoplasm. So you can kind of think of it as quote, two tones, if you will. It's got the amphiphilic and the xanthomatous cytoplasm. And that's fairly characteristic of the large multinucleated giant cells that we see in xanthogranuloma. These can be solitary lesions. They can be multiple. Sometimes they have been associated with underlying, I think it's a childhood acute myelogenous leukemia, and also they've been associated with the neurofibromatosis in some cases. So There are a couple of syndromes that can be associated with that. I'd probably recommend boning up on that too. But this is a nice example histologically of a xanthogranuloma. Okay. This is an interesting lesion also. So we just saw a benign neoplasm of inflammatory cells. Here we've got another situation. We've got a punch biopsy, very dense, diffuse proliferation of relatively dark staining cells once again. And they're not all just jet black. In some areas, you can see there's kind of a central light zone that's forming a small nodular aggregation of cells here. And then you've got these other cells that are really dark. And notice at low power, you've got this sparing of the area right beneath the epidermis. And I'm sure you all remember that that's called a Grenz zone. Grenz isn't named after a person. It's actually the German word for frontier. And it actually goes all the way back to the days where, army, when you're talking about a frontier in a European theater and whatnot, when they made the originally term was described, it really has more to do with the borders between countries, or maybe an area where you've got, one army is over here and the other army's over here, and this is kind of no man's land. Like in World War I, for example, that area between the two opposing sides was a frontier, if you will. So it's not like the wild frontier of the Wild West out here in the United States, but it sort of refers to areas between a couple of countries. So, and we talked about Grenz ray therapy that you may have heard of. Well, that's about as far as it penetrates. So the Grenz ray, which is radiation, we used to use it a lot in the old days for certain inflammatory skin diseases. It still is used by some dermatologists. It's a really good therapy when things don't respond, like steroids or JAK inhibitors. It actually can be used in chronic dyshidrotic dermatitis and things like that. We probably better drugs now, but in the old days, we used to use a lot of it. And it was called Grenz because that's about as far as it penetrates. It only goes about that far. It doesn't go down to the dermis and doesn't really cause any, serious complications down here. It's sometimes associated with skin cancer, but nothing deep. So here we got a dense nodular and diffuse infiltrate. Okay, so we've seen sclerosing pattern, we've seen follicular pattern, we've seen, inflammatory pagetoid pattern. Well, here we've got nodular and diffuse pattern. Okay. And that differential diagnosis is also not as many things cause that as cause sparse superficial perivascular dermatitis, which is the largest pattern of inflammatory disease that cause that pattern. So here we start thinking about maybe a neoplastic thing, maybe a lymphoma, maybe pseudolymphoma, maybe we think about an infection. We're going to look at the cells and see if we can get any other information there. And I mean, we pointed out low power. This really looks like a germinal center. These are the centrocytes. These cells are small. They're not really atypical. There's no mitotic figures. These are in the center, and the lymphocytes are surrounding it like a germinal center. In a condition such as follicle center cell lymphoma, we talk about inside-out follicular structures where the centrocytes are present kind of way out here, and there are lymphocytes in the middle. Or there's just no lymphocytes here. You just get a diffuse aggregation of all these centrocytes with no lymphocytes surrounding it. So that's what we see in follicle center cell lymphoma. This is more commonly seen in a pseudolymphoma. And the other thing we see in pseudolymphoma is a mixed infiltrate. We'll get lymphocytes, small lymphocytes that are typical. We often see eosinophils in pseudolymphomas. You don't have to see them, but we do see them here. And then we just don't see any atypical lymphocytes like you'd see, for example, in a nodular lesion of lymphomatoid papulosis. You don't see involvement of the epidermis. Pseudolymphoma is usually, it's also called cutaneous lymphoid hyperplasia, and it usually does not involve the epidermis. And this is what we refer to as a B-cell inflammatory pattern. And if you were to see a B-cell lymphoma, that also doesn't tend to involve the epidermis, like the T-cell pattern, what you see in mycosis fungoides. And so this is an example of a pseudolymphoma, a cutaneous lymphoid hyperplasia. Basically, it's where you're almost forming a lymph node in the skin. Now, sometimes we see a true lymph node. So let's say you cut out a basal cell carcinoma, and there's a little small lymph node down in here. That's a little bit different than where we see this pattern, which is truly forming like a lymph node in the skin itself because of an inflammatory insult. That's just where you just happen to sample a lymph node that was maybe in the plane of the excision. And this is usually associated with things like an insect bite reaction. Sometimes we see this with a severe florid allergic conjunctivitis. It's relatively uncommon in that setting. Sometimes it's just idiopathic, and we don't know for sure. But this is the type of biopsy that you really need to do to make that diagnosis. Sometimes we get shave biopsies of these lesions, and it's very difficult to make this diagnosis for certain on a shave biopsy. You just have a small piece of it. You really need something like this, and especially if you're going to rule out a lymphoma. And we're also, in a case like this, probably going to do some immune cell markers if we're concerned about it being a lymphoma, and things like looking for whether they're T cells and B cells, although we often get an admixture of cells in real lymphomas too. Usually you don't get B cells in a T cell lymphoma, but we very commonly see T cells in a B cell lymphoma. But then things like BCL6 positivity, BCL2 positivity in the lymphoid aggregates, those are things that kind of favor a lymphoma if we're looking for one of those things. But this is a benign lesion here, and it's a pseudolymphoma. Okay, another relatively large lesion here. And this is a nice example because this kind of breaks the rule a little bit. So there's for every rule we have in dermatopathology, there's always an exception to it. And so we have what looks like a neoplastic process. Till low magnification, these are inflammatory cells, and it doesn't look like garden variety epithelium. Something's different about this. And if at low power, it kind of looks like it was relatively well circumscribed. Looks like it was maybe kind of symmetrical. So, well, yeah, maybe it's just a large benign neoplasm. But there's the exception to that rule is that if it's a metastasis, it can give you a round, like cannonball metastasis that can be relatively small, relatively well circumscribed, and relatively symmetrical. So that's the thing you have to always think about when you're looking at a neoplasm. If it's got the cardinal features of benignity, you might just sort of ask yourself as a little aside, is there any chance it could be a metastatic process? And so when you're going to assess that, you're going to be looking for atypical cells, necrosis en masse, pleomorphism, things of that nature when you go to higher magnification. So sometimes you have to go to high magnification to make a definitive diagnosis. So we see here that this does not look like normal skin. Something is going on here. And it's got all of these clear cells in it. And these are epithelioid cells. They don't look like classic cells of the skin. They don't look like epithelium of that nature. If it's an epithelium, it's a different kind of epithelium. And notice that these cells are forming these little kind of elongated aggregations here. There's a mitotic figure. These cells are really very atypical. There's a lot of vascularity here, okay? And if you kind of look at this, if you remember back to your normal histology days in medical school, it kind of looks like a kidney nephron. And if you look at if you go back and look at the collecting tubules and the little glomeruli of a kidney, they have these white cells in there. It's got, and you know, basically just like the white cells that are in the eccrine sweat coil, those cells are very metabolically active, and they're actively using ATP. They have a lot of glycogen in their cells. So these cells too are clear because they have glycogen in them, and it just lets you reabsorbing ions in your eccrine sweat glands. You're reabsorbing ions normally in your kidney tubules. So it's the same process, similar kind of deal. So it's doing the same thing in your eccrine sweat gland that you're doing in your kidney. So that's why these cells are white, because they got a lot of glycogen. And so when you think of clear cell neoplasms that metastasize to the skin, you should always think about metastatic renal cell carcinoma. And these lesions also are quite vascular, just like the glomeruli, I've got a lot of blood vessels there. Well, these are also vascular lesions. In fact, these often present clinically as a vascular looking lesion on the scalp, and we clinically get these sent in as rule out a vascular lesion, like a traumatized angioma or something like that, angiosarcoma. They're concerned about that. So this is a metastatic renal cell carcinoma. Now, The board's not going to ask you too much about metastasis of lesions and expect you to look at it and make a definitive diagnosis. But this is one where they might do that because it's so prototypical. It's so classic with these clear staining areas here and all the vascularity. They might show you this and might expect you to recognize this as a metastatic renal cell carcinoma. So if you see a lesion that looks atypical, it's got a lot of clear cells and it's very vascular, think about the possibility of metastatic renal cell carcinoma. The other one they might ask you about metastatic breast, because that's got the classic diffuse cords and strands of cells between them on collagen bundles. They might ask you about a metastatic GI carcinoma, because that gives you the obvious glands with the central necrosis. But that's probably the extent of any mets that they might ask you about. I got time for one more, and this one's really a quickie. It's also one you need to be able to recognize pretty quickly. So here we got a punch biopsy, and so we have inflammatory neoplastic, and then we have one other category that's less commonly seen, but one you need to just remember, deposits and malformations. So is a malformation like a nevus sebaceous really a neoplasm? Yeah, not really. It's closer to a neoplasm. And then you have deposits of things. And so the board's going to expect to be able to recognize certain deposits. And this is a classic one. And if you look at higher magnification here, it's got this beautiful gossamer, wispy, it kind of looks like clouds blowing gently through the sky. And it's got this grayish color. And all of these little kind of gossamer little structures here, these are the residual ghosts of the crystals of gout. And this is exactly what gout looks like in the skin. It's pathognomonic. And these used to be crystals. Now, this is a water-soluble crystal, sodium urate. So when you process the tissue, it gets washed out. And so if you polarize this, it's going to be negative. You're not going to be able to see any of the crystals anymore. So you just have to recognize that it's got these nice little wispy, gossamer, it looks like spider webs, whatever you want to think of it like, that you see in the skin. It's pathognomonic of gout. And you can see that there's some crystalline-like structures here. If you take a biopsy of gout and stick it in 100% ethanol, then it will preserve the crystals. And you can look at that under the microscope, and they look brown. They don't look like this. They look brown, and you can polarize those, and you see these nice crystals that are in the skin. But if you just put it in formaldehyde, and then it gets processed, and there's water, it's water soluble, and you won't see the crystals anymore, but you can see the ghosts of where the crystals once were. So pathognomonic for gout. Doesn't look like, basically doesn't look like cholesterol. Those clefts those are little clefts that are more sharply angulated. They don't look loose and gossamer like this. Doesn't look like amyloid. That's kind of a bubblegum pink, starchy appearing globules in the skin. So again, that doesn't look the same here either. It doesn't look like colloid. Colloid looks sort of like bluish gray jello, and then it doesn't look like our deposits that we see or injectable fillers. So again, make sure you know how to recognize this, and make sure you know how to distinguish it from the other things that get either are injected into the skin or they're there because of some disease. Okay, well, I hope that was good for you, education for you. You're welcome to go back and review the video anytime. There's one more case on here. You can look at that on your own too. It's a mastocytoma. But in any event, hope this was a good session for you, and we will do this again next month. And you're welcome to go review any of the other sessions on our site here. We got lots of other videos on here that can teach you everything you need to know about passing the boards. Take care.